good evening to all of you. I welcome you all for this last session of Movement Disorders SIG. And today we have a interesting talk by our international guest, and then we'll have 5 brief case presentations. I request our President Dr. Shipala Gulati ma'am to introduce the speaker for today, the moderator and the expert for today's session. Over to you, ma'am.
Yeah, thanks, Mahesh. And just at the outset, thank you all for joining. Next week, we will be having a break because we have the national conference for Association of Child Neurology from 8th to 10th February in Vellore, CMC Vellore, where we all welcome you. So 7th session we will not have, but we will have session on 14th, and next month is the Neuroimmunology SIG. So I welcome you all to the SIG, in which today the movement disorders last SIG is the fifth one, fifth session, in which we'll be having an approach. Can I have the CV slides, Asmita? We'll have an approach to movement disorders case-based by Dr. Sanem Yilmaz, who's Associate Professor of Pediatric Neurology at the SIG Medical University, Izmir, Turkey. And she has areas of interest includes movement disorders, and she had spoken on a topic initially as well. And she has got multiple awards. And our experts for the day are Dr. Biju Hamid and the dear colleague who is and friend from Great Ormond Street Hospital, currently establishing the neurosciences in UAE, and neuro rehabilitation and movement disorders are his areas of interest. And Dr. Taj, who is who has been so kind enough for the 5th week in row to wake up in the middle of the night from Malaysia and joining us for this, and which shows his passion for movement disorders. And I mean, he's amazing professional with immense passion for movement disorders. And our third expert is our dear friend, Dr. Vinod Skaria, who is a physician scientist who has been our long-term collaborator. Initially, he was in IGIB, and now he has moved out of IGIB and is currently also he's also in IT Kanpur, but also in Bangalore. He's based in Bangalore currently, and really working on moving on the human genomes. And according to him, very soon we are going to be working on the whole genome sequencing and going to leave the others behind. And we would also moderator, for the session is Dr. Jitendra Goswami, who is as a professor and Department of Pediatrics, Command Hospital, Kolkata. And he has done his DM from PGI Chandigarh and his many publications, and amazing professional. I hand it over to you, Dr. Goswami, and just requesting you, I think army people are pretty strict, so you'll keep to time. 30 minutes is for Dr. Sanem. And after that, for everybody else, it's going to be 8 minutes. So maybe you can make it, after 7 minutes, you can flag it. Huh? So it'll be 8 minutes, and we're keeping 2 for discussion. And we have 5 cases. So actually, we had 7 cases, and then ultimately Mahesh brought them to 5. So we'll have to, you'll have to tell them, interrupt them at 7, so that, we have some time for discussion and move on. Yeah. Thank you. Over to you, Dr. Goswami. Dr. Goswami?
You need to unmute yourself.
Sir, unmute yourself.
Yeah, sorry. So thank you, ma'am. And at the onset, I would invite Dr. Sanem to start your presentation, please. You can share your screen.
Hello and good evening, everyone from Turkey. It's my pleasure to be here today, and I'd like to thank Professor Shalati and all the other members of the SIG for inviting me to this session. And today I'd like to make a brief description for diagnostic approach to childhood movement disorders with illustrative case presentations. As we know, movement disorders are defined as any excess or paucity of movements which are not due to weakness or spasticity and causing impaired performance of voluntary movements, presence of abnormal involuntary movements, and dysfunctional posture. Movement disorders in childhood are increasingly being recognized, and they are different than adults in many aspects, and diagnosis and treatment decisions are still challenging and time-consuming. And this is mainly because movement disorders are accompanied by many other neurologic and non-neurologic conditions, and it's very common in childhood that a child can present with more than one movement disorder at the same time, and the movement disorder may evolve as the child grows. The etiology of movement disorders varies a lot. A number of conditions in acute and chronic settings, including genetic, structural, metabolic, toxic, immune, infectious disorders, and also functional movement disorders should be kept in mind when we come across with a child with movement disorders. And today I'd like to provide a brief overview of diagnostic approach to pediatric movement disorders. The first step is to describe the phenomenology and classify the movement disorder. As we all know, movement disorders are generally classified in two broad groups as hypokinetic and hyperkinetic movement disorders. The prototype of hypokinetic movement disorders is Parkinsonism, and it's quite rare in childhood. And hyperkinetic movement disorders are dystonia, chorea, myoclonus, tremor, tics, and stereotypies. And as we all know, tics are the most common movement disorder in childhood, followed by dystonia, chorea, and hypokinetic movement disorders. So the first step is classifying the movement disorder. In hypokinetic movement disorder, there is only one type, and this is Parkinsonism, and is described as the presence of two of the four cardinal signs specific to Parkinson's disease. And this is a 17-year-old girl with a rare neurotransmitter disorder. And the first two videos demonstrates the bradykinetic movements, dystonia, loss of facial expression and associated movements, and disturbance of sequential movements. And the third video shows the oculogyric crisis, something lasting minutes for this case. This is a typical case of Parkinsonism. And the other type of movement disorders are hyperkinetic movement disorders. And dystonia is described as sustained or intermittent muscle contractions causing abnormal, often repetitive movements, postures, or both. And the first case is a case with DYT1 dystonia, and we can see how dystonia may affect both posture and movements in this case. And the second video is a case with KMT2B related dystonia, mainly affecting the lower extremity. And deep brain stimulation is being suggested to be placed as soon as possible for this gene. And the third video shows the effect of DBS and the improvement of dystonia of the case presented. And just to remind, PCAN is an important cause of dystonia in childhood, and tongue dystonia and opistotonic posturing is an important cause, is an important clue for PCAN disease in childhood. And the next movement disorder is chorea, and chorea is described as ongoing random appearing sequences of discrete involuntary movements or movement fragments. It can be caused by genetic reasons, which is mainly due to NKX2-1 gene and benign hereditary chorea. And sometimes it can be the reason for many other serious conditions. And we should always be aware that in case of acute and subacute onset chorea, the most common cause is Sydenham's chorea, as seen in the first two videos, with random appearing purposeless movements and darting tongue. And just to remind, autoimmune encephalitis may also present with choreatitoid movements and severe facial kinesia. And this is the other case with GNA01 disease, and we can see her prior to DBS placement and after DBS placement. And the next movement disorder is myoclonus, and it is defined as quick, shock-like jerks due to sudden involuntary contraction of one or more muscles. And the first video shows the myoclonic movements triggered by stimuli in a case with hyperexplexia. And the next video shows a case of progressive myoclonic epilepsy due to Lafora disease, and we can see the several myoclonic jerks, both epileptogenic and non-epileptic in origin. And another cause is subacute sclerosing panencephalitis, and it is a devastating cause of myoclonius associated with cognitive decline and seizures caused by a slow virus infection due to measles. And the next is tremor, and tremor is defined as rhythmic, relatively symmetric, oscillatory, involuntary movements about a joint axis. And tremor may be physiologic tremor or essential tremor, or it may be the presenting symptom of some serious diseases, such as Wilson's disease, as seen in the first video. And also, we should always keep in mind the probability of functional movement disorders, and we can see the distractibility, intrainability in the second video, which suggested the functional disorder. And the other movement disorders seen in childhood is stereotypies, and they are defined as involuntary, rhythmic, repetitive movements that appear purposeful but meaningless and stop with this distinction. And this is a case, and we know that stereotypies alone have no prognostic value, and this is the case with no health problems. And she describes stereotypic movements while being fed by his mother. But the second video depicts a girl with Rett syndrome due to MACPT mutations exhibiting developmental arrest, microcephaly, and hence stereotypies, which is seen in girls. And after classifying the movement disorder, the next step is thinking about the additional findings like epilepsy, dysmorphic features, microcephaly, intellectual disability, systemic findings, and of course the family history. And the next step is trying to define the underlying etiology by always considering the congenital and acquired causes. And the clinicians should also focus on whether this is a treatable disorder, this requires a symptomatic treatment, or is it a preventable cause? So the clinician should think about which laboratory tests should be done. For summary, the diagnostic workup includes the phenomenological classification by providing the prevalent movement disorder and the accompanying movement disorders, and other features including dysmorphology, epilepsy, intellectual disability, and autistic spectrum disorders. A pedigree helps us to understand the genetic transmission of the disease. Laboratory and imaging findings will make us go to the diagnosis. And if we think about the genetic reason for the movement disorder, it's now the decision time for which genetic test should be done. It is always not easy to decide which genetic test should be done because the same phenotype may be caused by different genes and even by different genetic mechanisms. And also, the same genotype may cause dystonia in a case, chorea in another case, and even epilepsy or only intellectual disability in other cases. So let me make a diagnostic approach for genetic test selection. If we have a specific diagnosis for the movement disorder, we can perform a single gene analysis or MLPA analysis. If we have some accompanying features like dysmorphology, autistic spectrum disorders, or maybe epilepsy, we can first request microarray analysis. But if we do not have any specific diagnosis or more than 2 possible genes for the diagnosis, we can make next generation sequencing panels, clinical exome sequencing, whole exome sequencing with copy number variations, or whole genome sequencing. It depends on the laboratory and some economic conditions. But even if we all do these diagnostic processes, we should always keep in mind the encoding regions, the mitochondrial disorders, and also the triplet repeat expansion diseases. Now, I'd like to talk about 3 cases which makes a different diagnostic approach and some clues for diagnostic approach in cases with movement disorders. The first case is a 10-year-old girl. She referred for ongoing staring episodes, and they were recognized at the age of 3. And these staring episodes were related to hunger. And because of this, when she was an infant, it was suspected for hypoglycemia, and the results were normal. Then it was thought that this is absence epilepsy, and she was prescribed valproate and ethosuximide. These therapies decreased the number of seizures, but she never had full seizure control. Her physical examination revealed microcephaly, intellectual disability, and dysarthria. And the EEG performed revealed the typical childhood absence epilepsy. And also, the mother of the case described some walking abnormalities in this case. She told us that she has some difficulty walking after a specific period of time. And in the first video, we saw that abnormal walking, but in the next video, after a while for walking, we can see the dystonic posture of the right arm and right leg of the case. And this was compatible with paroxysmal exercise-induced dyskinesia. And if we summarize, the case had early onset childhood absence epilepsy, which were triggered by hunger and fatigue. She also described paroxysmal exercise-induced dyskinesia, microcephaly, dysarthria, and intellectual disability. So we thought about the diagnosis of GLUT1 deficiency and requested to perform a lumbar puncture to the parents. But the parents told us that in 2016, a genetic analysis was done for this disorder and turned back normal. So we requested the reanalysis of this SLC2A1 gene, and this was normal too. But since the clinical clues were very clear, we decided to perform a lumbar puncture and saw that CSF glucose was 34, and the CSF serum glucose ratio was 0.37, which is compatible with the suspected diagnosis. And when we searched the literature, we saw that SLC2A1 mutations may be detected in sequencing analysis in 84%, while 13% of the cases may be caused by deletion or duplication mutations. So when we made the MLPA analysis, we saw a big heterozygous deletion in 1 to 10 exons of the SLCA21 gene. So this case was diagnosed as GLUT1 disease, and ketogenic diet had significant seizure and cognitive outcome. And the second case is a 3.5-year-old girl which had second-degree consanguinity between the parents. She had normal history of pregnancy and birth, and normal developmental milestones up to the 4 months of age. And then at 4 months old, she described hypotonia, and she was unable to hold her head at 6 months of age. And she also described episodes of upward eye deviation at 11 months of age, which were consistent with oculogyric crisis. For this reason, the metabolic analysis, electrophysiological studies, and cranial MRIs were done, and which were all normal. And she was suspected for a neurotransmitter disorder and had some abnormalities which are not diagnostic for a specific neurotransmitter disorder. So she was diagnosed, she was started a low dose of L-Dopa carbidopa, but she could have no recognizable effect. And the whole exome sequencing analysis with a preliminary diagnosis of neurotransmitter disorder came back as a likely pathogenic mutation in a gene that causes Joubert syndrome. So when we search the literature, we know that molar tooth sign is a specific finding, and the cranial MRI was re-evaluated, and no significant findings suggestive for Joubert syndrome was found. And here is the case when we first saw her at the hospital. She had difficulties holding up her head and was unable to sit without assistance. And she also, due to the oromandibular dystonia, she was also unable to close her mouth. So although the genetic studies did not support the diagnosis of a neurotransmitter disorder, due to the clinical findings strongly suggestive, we increased the L-Dopa dose to a therapeutic level. And just after increasing the L-Dopa dose, she began to sit without assistance, was able to open her fingers and handle a pen, and also could be easily fed by her mother, and was cognitively improved. And at the third month of therapeutic dose of L-Dopa, she was even unable to walk independently. As we suggested a reanalysis and requesting all the previously described mutations, the scientific research lab turned back to us that a homozygous mutation at the regulatory region of the tyrosine hydroxylase gene was detected. And we searched the literature, so we saw that not only the exonic mutations, but the encoding regions or regulatory region mutations can also cause tyrosine hydroxylase mutations. So this was reported in a literature, and they thought that if no mutations are found in the coding regions of the tyrosine hydroxylase gene, the search for pathogenic mutations should be extended to regulatory promoter elements. So in a case we are suspected about neurotransmitter disorders or any kind of disorder, we should be sure about the laboratory is studying all the pathogenic or genetic mechanisms that may cause the disease. And here is the last case. This is a 16-year-old boy. He was diagnosed with cerebral palsy and epilepsy. He had normal development until the age of 6, and he had some hyperactivity. And after that, at the age of 6, he started to have difficulty in walking, inversion of the feet. He had dysarthria and some epileptic seizures, mainly myoclonic epileptic seizures, at the age of 11 started to occur, and they were all drug resistant. And the cranial MRI of the case showed that there is a hyperintensity at the caudate and the putamen. And when we looked at the other cranial MRIs with thiamine biotin responsive basal ganglia disease, we thought that our case's MRI findings are very similar to this disease. So we started to give him thiamine and biotin treatment. Before the treatment, he was very bradykinetic, hypomimic, and he was unable to walk. And after thiamine and biotin replacement, he improved and even started to stand alone and could be walked with a support. And then we waited for the whole exome sequencing analysis, and it was normal again. And we requested a reanalysis specific for thiamine biotin responsive disease, and it was also turned back normal. We started to think about mitochondrial panel, and we made a radiology consultation, and our neuroradiologists told that this is a caudate and putamen atrophy rather than a hyperintensity. So this atrophy reminded us the Huntington disease. And the Huntington disease triplet repeat expansion analysis of the case revealed that, as we can see and as we compare for the negative control and the positive control, it suggested the Huntington disease. And the triplet expansion number at one allele was found as 85, which is compatible with the suspected disorder, and the case was diagnosed as Huntington disease. And how could we explain the thiamine and biotin responsiveness in this case? We searched the literature and read about clinical trials on the effect of thiamine in Huntington's disease. The mechanism was that the repeated expansions of the Huntington gene was downregulating the thiamine transport and leading to a functional deficiency in central nervous system, and thus high doses of thiamine and biotin may allow to bypass these defective transporters. So this case was diagnosed as Huntington disease, which we know that it presents with dystonia in childhood rather than chorea in adulthood. In conclusion, diagnosing and treating movement disorders in childhood requires a multidisciplinary approach, including pediatric neurologists, Department of Neuroradiology, genetics, and metabolisms, to be able to see the whole picture. And I'd like to thank all my team that everyone has invaluable contributions to this work. Thank you very much.
Thank you, Dr. Sanam, for the excellent lucid presentation. Here, can we take one quick comment from our experts? Dr. Biju, would you like to say something?
Fantastic, Sanam. And I think those three cases very nicely elucidated the difficulty in managing these children and like making a diagnosis, even though, and also it highlights the importance of the clinical suspicion, isn't it? In all three cases, at least in the first two, the clinical suspicion was always there. And this is one danger in going for, I thought, going for whole exome sequencing straight away, and as we often are culpable of doing at the moment, it's always going back to the clinical findings, and then repeating it and then looking at it again and again. That's very, very important, and I think that's fantastic. I thoroughly enjoyed the talk, and those three cases were clearly examples of how to approach movement disorders. Fantastic. Thanks, Dr. Sanam. Thank you.
Thank you so much.
Thank you. And would you, Dr. Taj, would you like to say something? Would you like to add something?
Thank you, Dr. Sanam, for a very good talk. So, I mean, I totally agree with what Dr. Biju has highlighted. Is back to phenomenology plus your clinical findings. For example, the case of thyroxine hydroxylase that you depicted. Although the genetic testing was suggestive of Joubert, but Joubert does not present with that extent of what you call hypotonia. It's like a floppy baby syndrome, even worse than a child with SMA. Thyroxine hydroxylase is one disorder that presents with severe hypotonia, so unlikely unlikely to be a Joubert. Although the eye movement disorders, where in Joubert you tend to sometimes come across certain forms of Joubert, you come across oculomotor apraxia, whereas in thyroxine hydroxylase is predominantly oculogyric crisis, can be confused by the hypotonia itself is definitely more of a neurotransmitter, thyroxine hydroxylase, rather than a Joubert. I agree with Dr. Biju and yourself. It's back to clinicals, phenomenology, and then trying to correlate with the clinical science, not to do a gunshot approach straight away to whole exome and trying to negatively phenotype. Many at times it may lead to what you call erroneous clinical judgment. Thank you.
I
Today
may
we
add one thing, Dr. Goswami, one thing, and we should have our very important clinical radiological meets, and they should be one-on-one, and they should be discussion with the clinical and the radiology team. I think that's a very great learning thing, and where we come to arrive at diagnosis. Before Dr. Vinod, our physician scientist friend, is going to speak, Professor Hassan, your comment from Turkey. And Dr. Sanam, it was amazing talk. Thank you so much. And wonderful cases, and dot on time you finished. Dr. Hassan, I told you that Jitendra Goswami is from army, so you finished on time. I hope. Yeah, Professor Hassan.
Hi, Dr. Shefali.
Hi.
Thank you very much for your nice words, and then thank you, Sanem. Excellent presentation, and all the comments, the Jules and the Bijou. Yeah, it is really exciting, and we are very happy to be involved this webinar to discuss the movement disorders as separated this month. And then I really enjoyed that all the webinars, and also I would like to thank Sanem for your excellent presentation. Thank you very much, Dr. Shefali, inviting.
Thank you. Yeah, thank you, Professor Hassan. No, we are all a team, and actually we have a break next week. As I mentioned, I think you joined later because we have a national conference coming up, annual conference in Vellore from 8 to 10. So 7th will be off, but we come back on 14th with the neuroimmunology session, SIG. And I need the final word from Dr. Vinod before we go to the cases. Dr. Vinod Skaria, our physician, scientist, friend, collaborator, has been actually all of Dr. Vinod.
Yeah, thanks, Professor. It's a fantastic talk, Dr. Sanam. Sort of quickly going from the clinical picture to the genetic test and sort of correlating the genetic test back to the clinical phenomenology. I think, I mean, one point, or the only point that I have to make is, of course, in some cases, you do have discrepancy in what the genetics says and the clinical features. This could largely be because of two things. One, the genetic variant is probably not the right variant. Or second, probably there is issues with penetrance, which or disease modifiers, which also needs to be looked at. I'll stop there. Thank you very much. But fantastic talk.
Thank you.
Thank you, Doctor. Thank you so much, Dr. Sanam. Dr. Goswami, I think Asmita has said that the first speaker is not in the panelist, so you can call the second one. Yeah.
Okay, ma'am. Thank you, ma'am. So now,
and after 7 minutes, you will flag, right? Yeah.
Yeah, definitely, ma'am. So as ma'am has told, we'll the presenters are requested to stick to time. So we'll start with Dr. Grishma Baby from Medical College, Kolkata, and the moderator would be Professor Kalpana Datta.
Okay.
Please share
Good
your screen.
evening, sir.
1 second, Dr. Mahesh, can you correct it, please? Mahesh.
I'm done. I'm done.
Yeah. No, actually, I'll just, there is a typographical error. Is Dr. Kalpana Vijay will be the expert, and and this is from Trivandrum.
Okay, I stand corrected, ma'am.
Yeah. There was a typographical error in the older one. Yeah. Thank you, Dr. Kalpana Vijay. You also joined. Thank you so much. Yeah.
Can I start presenting, madam?
Please do.
Family history. This is a 6-month-old girl, second born of third-degree consanguinity. There is no history of any perinatal insult. At 2 months of age, noted to have global developmental delay, opistonic posturing, and episodes of abnormal deviation of eyes. There was sleep disturbance and excessive sweating and pooling of saliva. This is the video. Here we can see the opistotonic posturing, dystonia of both upper limb and lower limb. Upper limbs are kept extended, pronated, and fisted. And there is eye deviation, convergence of eyes. The child is interacting with the baby is interacting with the brother. These episodes will last for 3 to 4 hours continuously. Now the child is there is eye deviation to left side. We have done video EG multiple times. There was no ictal correlate and the EG was normal. And initially, this child was we gave anti-seizure medication, but there was no response to the treatment. Episodes of dystonia. On examination, there was no dysmorphic facies. There was microcephaly, excessive sweating and pooling of saliva. There is no failure to thrive. There was axial hypertonia and mild hypertonia of extremities. There was episodic dystonia and opistonic posturing. Reflexes were bilaterally exaggerated. MRI brain showed brain atrophy, pericivilian atrophy. EEG was normal. TMS was normal. Phenylalanine levels were normal. Since the child had all these oculogyric crisis and dystonia and CSF, pterins, neopterins, biopterins were done, which was normal. CSF and urine, HbA and HIAA, homovalinic acid and HIAA was not available. Whole exome sequencing done showed infantile dystonia, Parkinsonism type 2, homozygous autosomal recessive mutation of SLC18A2 gene, which codes for VMAT2, vesicular monoamine transporter 2 protein. Infantile dystonia, Parkinsonism type 2, is a neurodevelopmental disorder, belongs to monoaminogenic neurotransmitter deficiency states without hyperphenylalaninemia. There is mutation of SLC18A2 gene, which codes for VMAT2, that is vesicular monoamine transporter 2 protein. Children present with dystonia, poor motor skill, autonomic dysfunction, and abnormal sweating, oculogyric crisis, and poor sleep. For this child, we started with L-DOPA. There was no improvement. They worsen with L-DOPA and show improvement with DOPA agonists like pramipexole. So here, this pathway, the phenylalanine will be converted into tyrosine from levodopa, dopamine. So VMAT2 basically facilitate the dopamine and serotonin loading into the synaptic vesicle for their transportation to the cell membrane and subsequent release. VMAT2 help in dopamine and serotonin loading to the vesicle and transportation to the cell membrane. So here VMAT2 is a mutation because of the SLC18A2. So when we see the red flag signs of neurotransmitter deficiency like dystonia, mixed movement disorder, diurnal variation, autonomic dysfunction, levodopa responsiveness, if the clinical history and examination are fitting, then CSF pterins will be doing. If the CSF pterins are normal and in our case, HbA is not available CSF, but if the urine, HbA and HIA are increasing, then it points towards the VMAT2 deficiency and SLC18A2. So monoamine neurotransmitter disorders, there can be primary disorders or because of the secondary defect in other disorders. In the primary disorders, there is cofactor deficiency, vitamin B6 and biopterin deficiency. And because of the enzyme deficiency like tyrosine hydroxylase, aromatic amino decarboxylase, dopamine, beta hydroxylase or monoamine oxidase deficiency. Or there is defective transport and reuptake, that is the DAT deficiency, dopamine reuptake deficiency. Or like our case, defective vesicle formation and packaging, where there is VMAT2 deficiency, where not only dopamine and serotonin, both dopamine and serotonin vesicular transport will be defective. That's why they are showing features of dopamine deficiency like Parkinsonian features and serotonin deficiency like sweating, serotonin deficiency features and norepinephrine deficiency features. Our child actually on pramipexole showed mild improvement but this child is still having global development delay and not attaining milestones. Thank you.
Any quick comment from the moderator?
Dr. Kalpana Vijay, ma'am.
This was the first case that of infantile dystonia Parkinsonism that was seen. So this case was initially baffled us a lot, and we were thinking like seizures, and later on only we could identify that it is oculogyric spasm, as it used to last very longer, and along with that there is autonomic features like child was not at all sleeping and was having sweating, excessive sweating, and excessive cry, irritability, and sleep problems. Along with that, this prominent oculogyric crisis with full consciousness, and that made us think about neurotransmitter diseases. And the investigation proved that it is a VMAT2 mutation. So we have started on very low dose of pramipexole. Initially, there was improvement, but the child was very sensitive, and they have found it difficult to manage. And then we have put the child on small dose of bromocriptine, to which child has responded in the sense that the oculogyric crisis and the dystonic crisis have come down, but the child didn't attain milestones. Child is still, now it is about 2.5 years old, and still only partial head control is there. So that is the thing. And whenever we see oculogyric crisis among the neurotransmitter disease, we have to think about AADC, or aromatic amino acid decarboxylase deficiency, as well as the sepiapterin reductase deficiency, along with the VMAT. That are the commonest conditions that can come with this one, and also tyrosine hydroxylase also. That's the way.
Thank you, ma'am. Now I call upon Dr. Diksha Gupta from AIMS Rishikesh.
Wait, Dr. Goswami, the experts have to give their comments, please. Yeah, we have next 3 minutes for experts. Yeah, please. Dr. Biju.
Fantastic case, and again, clinically, it's very classical infantile Parkinsonism dystonia, and as Dr. Kalpana said, the oculogyric and dystonic crisis are quite characteristic, and it's very often it is very clinically indistinguishable from like AADC deficiency, for example. And it's interesting, like we also recently had a child with, which was published recently in Cells, like again, classical infantile Parkinsonism dystonia, but the characteristic thing was like no response to dopamine agonists. And in fact, even functionally in cultures, we showed that it was no response to either bromocriptine, pramipexole, or proticotin, apomorphine, everything. And then finally, we found that there was a homozygous variant in the dopamine receptor gene, DRD1, resulting in loss of function of the D1 receptor. And I think, to our knowledge, that was the first report of a monogenic disease associated with D1 receptor dysfunction. So when the child classically presents with infantile Parkinson's dystonia, and then if you don't find response to a dopamine agonist, then we have to again look deeper into and like what we found with the D1 receptor dysfunction. So and then there is a clinical role in finding if there is any possible monogenic causes to be found, because now we know that gene therapy for AADC deficiency is there. So similarly, there is a benefit in trying to dig deep and find these diagnoses. But clinically, yes, the key take-home points would be with the oculogyric and dystonic crisis, AADC deficiency should always be borne in mind and thought about that, because it's treatable. Fantastic case. Thank you.
Thank you, Dr. Biju. Amazing case. Dr. Taj. Dr. Taj. Rishma, this will be mailed to you, the certificate. Yeah.
Thank you. Yeah, it was a very good case. The few things to highlight is that children with SLC 18A2 who present with infantile dystonia Parkinsonism tend to have significant developmental delay. It's depicted by the fact that even there is cerebral atrophy. it's good to take note that they tend to sometimes worsen with L-DOPA, and of course, everyone's what you call first approach would be to start on levodopa when a child has got dystonia and or Parkinsonism, dystonia, Parkinson rigidity. Sometimes one of the drugs that I've tried before, two of my patients, so one was confirmed genetically, the other one was confirmed by neurotransmitters. I tend to do lots of neurotransmitters. Benzodiazepine stands to help. I don't really know how to scientifically or biologically explain how benzos work, but tend to work for so many things. But they tend to work and they reduce the durations of opistotonic posturing and opistotonic episodes, and some of the oculogyric episodes, and the child will be slightly more than less distressed and more comfortable. Thank you.
Thank you. Dr. Sanam? You want to add something, Dr. Sanam?
Thank you. It's really an interesting case. And we have similar two cases, two siblings, and one of the siblings I showed in my presentation. And as the presented case, pramipexole unfortunately didn't make any improvement in our cases. So SLC18A2 disorder seems like a treatable disorder. Maybe we are quite late in diagnosis this disease, and we cannot make a progress despite pramipexole in these cases. Thank you.
Thank you. Dr. Hassan, you want to add something before Dr. Vinod says something? Professor Hassan. Dr. Vinod? Dr. Vinod Skaria? Go to the next case. They have nothing to add. Dr. Goswami, get the next case on.
Yeah, Dr. Diksha from AIMS Rishikesh, please share your screen. The case would be moderated by Dr. Prateek Kumar Panda.
Good evening, sir. Sir, my screen is visible and I'm audible?
Yes, please.
Yes, you're audible. Okay. So, good evening, everyone. So, today I will be presenting a case of an adolescent boy with paroxysmal non-kinesiogenic dyskinesia under the guidance of Dr. Prateek Kumar Panda, sir. So, we had this 11-year-old boy with history of recurrent attacks of sudden onset bilateral involuntary twisted bizarre posturing like movements of upper and lower limbs. These were since last 3 years. This lasted for about few minutes to half an hour, and the frequency of these episodes were 1 to 2 episodes per week. These episodes occurred predominantly spontaneously, and some events were, however, precipitated by excitement, stress, and fatigue. There was complete resolution of these episodes without any residual dystonia or involuntary movements. These episodes were not precipitated by consumption of tea, coffee, or hunger, and there was no preceding aura or diurnal variation. There was no history of any loss of consciousness, uploading of eyes frothing from mouth, or bowel bladder incontinence, no prodromal febrile illness, sore throat, or vaccination. There was no associated flinging movements, hemibalismus, or gait abnormalities, no cognitive decline, or any similar complaints in any of the family members. So the systemic examination was completely normal, and also the neurological examination was normal. This was the video of the child in which we could see that there was this sudden involuntary bizarre movement in which the child had inward twisting posture of the upper limbs predominantly more than the lower limbs, and also there was tonic contraction of the face. Also, this child also produced sound stridal. The child also produced some moaning like sounds, and there was also blepharospasm. These episodes usually lasted for about minutes to hours together, and it used to subside spontaneously. So as we can see in this video, this episode used to last for minutes to hours together with this twisting posture of the upper limbs. So we upfront kept the possibilities of paroxysmal dyskinesias, PNKD and PKD. Paroxysmal non-kinesiogenic dyskinesia was high on cards as this was childhood onset disorder with hyperkinetic movements which lasted for minutes, predominantly involving the face, trunk, and the limbs with predominant dystonia. And these episodes were triggered by excitement and stress. There was no premonitory sensation, however. Paroxysmal kinesiogenic dyskinesia also presents in a similar manner, but these episodes were not triggered by sudden voluntary movements which would happen in PKD, and the episodes were less frequent and they did not happen on a daily basis, and there was no preceding aura. Other causes of secondary paroxysmal dyskinesias were considered like autoimmune vascular metabolic, but there was nothing to suggest the same, and there was no history of any drug intake as well. Apart from these, tetany or carpopedal spasm could have been considered because there was sudden involuntary attacks with twisting, but there was no chopstick sign, tingling, numbness, or weakness in any of the limbs. With these videos, we can also consider a possibility of PNES. However, there was no obvious stressor, and this episodes were short lasting, and there was no post-ictal mannerisms. Then, very lower down on the cards, I would like to keep possibility of generalized tonic seizures because of the tonic posturing of all four limbs, but there was no loss of consciousness, postictal confusion, or any bowel bladder incontinence. We went ahead with investigations and we could see that the serum calcium, vitamin D were normal. Serum ceruloplasmin, TFT, so titers ANA was also negative. The MRI brain was done outside, which was normal, and video EEG with suggestion was done, but however, the same event could not be reproduced. So we went ahead and treated the child with clonazepam, thinking on the lines of paroxysmal non-kinesiogenic dyskinesias, but there was just partial reduction in attack frequency on starting clonazepam. Meanwhile, we had got the clinical exome report, which showed us that there was a heterozygous missense mutation in the exon 2 of the PNKD gene located in chromosome 2, in which proline was substituted for alanine at codon 33, and this was most likely a likely pathogenic mutation. So we went ahead with treatment with other options like levetiracetam and gabapentin. After this, we saw that there was a reduction in attack frequency significantly, and we advised the parents to avoid precipitants for the attack. However, still occasional attacks were present, but the frequency was definitely reduced from the baseline. Thank you.
Dr. Pratik?
Only thing I wanted to, am I audible, sir?
Yes.
The only thing I wanted to point out is the most common gene we found out is myofibrillogenesis regulator gene. But in this case, the stressors were, that the precipitating factors were not that much clear, and usually those who don't have MR1 mutation, they can have variable age of onset, variable clinical feature. Alcohol we could not try because this was, and there was no history also, and that was it is adolescent boy. So we were not sure what kind of gene we are going to get really, but we were thinking if we might not get MR1 gene in this case, and the child still continues to have occasional attacks. So actually, I wanted to know what we can do further, but these attacks are not disabling to the child anymore.
Can we have the comments of the experts, please? Dr.
Dr.
Biju, sir?
Taj. Dr. Taj has raised his hand. Dr. Taj has raised his hand. Dr. Taj?
Yeah. It's a very interesting case again. Just being a devil's advocate here. So looking at the phenomenology itself, most of the PNKD and KCNMA1, they present in a more hyperkinetic manner. So chorea seems to be slightly more common than the phenomenology of dystonia per se. Even for those who present with dystonia, the dystonic posturings are lesser versus more of dystonic movements, twisted movements with repetitive and twisting posturing, rather than such a fixed, what we call posturing from the word go till the end. So one look for this child based on the phenomenology, I probably would want to look at the what you call psychogenic or functional movement disorder. But interestingly, the genetic mutation is positive and the child seems to be improving. So just my thoughts on that.
Biju?
Yeah, interesting. Benzodiazepines being tried, clonazepam?
Yes, sir. The first drug which we tried was clonazepam, sir.
Okay. Yeah, I mean it's in terms of the phenotype, I think I don't. Yeah, I mean Dr. Taj feels otherwise, but I don't know why the phenotype was suspect, Dr. Taj. I mean, the history and the clinical features were sort of in keeping with the diagnosis, wasn't it?
yeah, to a certain extent, the history was consistent, except, trying to elicit the part where the triggering factor for PNKD, which sometimes can be stress, food, or certain environment. So that can be quite confusing because the majority of the PNKDs that I've seen, they are chorioathetotic or choreoform. The smaller portion of them, which are KC and NMA1s, they tend to have dystonic movements rather than fixed dystonic posturing. So whenever a child presents with very fixed dystonic posturing with a good GCS and alertness, we tend to think of something like that.
I agree.
Sanam, Dr. Sanam.
Thank you for the nice talk. Maybe I can have a question for the experts. When we see the PNKD gene analysis as normal, what should be the next step with cases very compatible with the diagnosis of PNKD, but not all these cases are can be detectable genetically. Do you have any experience?
I think I would agree with what Dr. Vinod Skaria was saying earlier. In terms of, I think, like again, the typical example would be with the PRT2 ones. With the epilepsy and movement disorder and the migraine and everything. It must be down to the penetrance, I suppose. I mean, that's the only explanation because, even with the paroxysmal dyskinesias, we know very little in terms of phenotype. And recently, like in the last few years, there's been a spate of papers looking at the phenotyping in this condition. But still, I think we know very little correlating the pathophysiology and the phenotype, and also the age at which the condition onsets, in the age of onset, epilepsy versus the movement disorder. I don't know whether if Dr. Vinod is still here. I suspect, like at least in PRRT2, I think it is down to penetrance because we know that the penetrance is very high in case of epilepsy and low penetrance in case of when they present with movement disorders. So,
thank you.
If you end up with a blank on testing, I don't know what you would do.
Probably go clinically. I mean, 10 years ago, there was no genetic testing. So all our diagnoses were based on clinical assessment and clinical trial and go with medication. So if the genetic testings in a whole exome or the, targeted testing comes back as negative, then a trial of, carbamazepine or trial of clonazepam, phenytoin. One of the drugs that sometimes, we tend not to use that much in pediatric age group is phenytoin. So I've got cases of PKDs, which were mutation negative and did not respond to carbamazepine. And I wasted the patient's money sending back again genetic testing with another company, trying to question maybe, this company kind of missed it, but still was negative, but responded to phenytoin. So probably our clinical equipment and clinical assessment probably should come first. Then, of course, lean back on the genetic mutation.
And also, I was speaking to our clinical geneticist the other day, like, we are talking about genetics and autism. And then the current thinking is that at least you should do a whole genome sequencing. And then at least we should repeat the whole genome sequencing at least every 2 to 3 years.
I think that is a real. We had that big talk also at the time with Vinod was there. I think Dr. Goswami, there's some questions in the chat. You can just take very quickly before you go to the next one. I think Vinod was traveling, so I think he'll join us in between. I think.
Was acetazolamide also helps in PNKD? Can try if not tried. That was rather a comment. And
carbamazepine. Yeah.
There was one, did you try carbamazepine for these events and patient with PNKD?
We didn't try carbamazepine. We tried clonazepam, and by the time in the next time they visited, we already had that report of exome sequencing within the next 1 month. So I think carbamazepine we find literature for levetiracetam and gabapentin in PNKD. but we could not find. So we have not tried yet for carbamazepine, but we will definitely try acetazolamide, sir, and they visit us on follow-up, sir.
So can we go to the next case, ma'am?
Yeah, please.
So now, Dr. P. Sindura from Lilavati Hospital, Mumbai, please share your screen. And the moderator is Dr. Shilpa Kulkarni.
Good evening, everyone. I'm Dr. Sindhu, working as DRNB resident in BJ Vadia Hospital, and my guide for today's presentation is Dr. Shilpa Kulkarni. Today, we are going to talk about the biography of boxing blue babies. Why it is named as that, we'll learn soon. So it is here we are discussing about two cases. First case, 5-month-old boy, first by birth order born out of non-consanguineous union, came with chief complaints of not achieving age-appropriate milestones, abnormal posturing and tightening of the body noticed since last 3 months. Her developmental history showed there was no neck holding, no rollover, does not recognize mother and does not respond to sound. There is a history of poor weight gain also with feeding issues. Weight of the child at present was 4.5 kgs. Her birth history was normal, normal vaginal delivery with a birth weight of 2.9 kgs with no NICU stay, no history of neonatal jaundice and a smooth perinatal transition. On examination, child was alert. The child had microcephaly with her head circumference of 36 centimeters. There was retroscolus. Mild dysmorphism was there in terms of prominent metopic suture and hypertelorism. There was no organomegaly. Tone was increased with brisk reflexes in the lower limb, and there was significant oromotor dystonia, as we can see in the video. So coming to the summary of the child, 5-month-old baby with normal birth, global delay, microcephaly, predominant oromotor dystonia with retrocollis, failure to thrive. Probably the localization could be basal ganglia with plus or minus cortex. So my DDs at this point of time would be HIE, kernicterus or torch infections. Although the antenatal history was normal, we would still consider it. Probably IEM or like including organic acidemias and mitochondrial disorders, although there were not much metabolic decompensations. Aicardi-Goutieres syndrome, but there were no seizures. Leach-Nyhan syndrome and sometimes probably neurotransmitter disorders, although microcephaly is present in some types like sepiapterin reductase deficiency. So with all these DDs in mind, we went ahead with the investigations. His metabolic profile was normal with normal ammonia lactate, VBG, SGOT, PT were normal. Newborn screening with TMS was negative. Uric acid was normal. Ophthal and Bera was normal. We also did his MRI brain, which showed hypoplastic corpus striatum, cerebral and cerebellar atrophy, delayed myelination, subtle delayed myelination in terms of absence of subcortical occipital white matter myelination. And the MRS of the child was normal. Radiologically, it was suggesting like HABC, hypomyelination with atrophy of basal ganglia and cerebellum. So post 15 days later, child got admitted with upper respiratory tract infection with mild tachypnea. On room air, the saturation was 88%, and even after giving 100% of O2, the saturation still remained 91%, and hence an ABG was performed, which showed bicarb of 19, pH of 7.4 and saturation of 95, but methemoglobin was there, which was 13%. Normal methemoglobin levels should be around less than 2%. So at that point of time, we did 2D echo to look for the cyanosis. It was cyanotic heart disease. It was normal. Child received symptomatic treatment and he was discharged. So we thought that methemoglobinemia was probably because of the sepsis. And still, keeping the consideration of HABC, we have sent a genetics. 1 month later, a similar case has come. A 2-month-old baby, first by birth order born out of 3rd-degree consanguineous marriage, presented to us with fever, lethargy, loose stools, and respiratory failure noted since 3 days. Same, SpO2 was 86 on 100% of room, 100% O2. Chest X-ray 2D echo were normal. ABG revealed acidosis. Weight was 1.9 kgs, and the baby had term delivery with IUGR. The birth weight was 1.7 kgs. On examination, child also had hypotonia with dystonic posturing and microcephaly. This was the video where you can see significant dystonia present with retrocollis. Methemoglobin levels at that point of time were also significantly high, 65%. Methylene blue was given, bicarb correction was given, child improved eventually, and MRI was done. His MRI brain showed almost normal findings except subtle prominent cerebellar foliae, suggesting probably early onset cerebellar atrophy. So coming to the summary, 2 children presented with early onset dystonia, global delay, microcephaly with no significantly evident cyanosis on and elevated methemoglobin levels and atrophy on brain imaging. At this point of time, we were not sure whether methemoglobin levels has any neurological associations. So we were doing some literature review. Meanwhile, we got the genetic whole exome sequencing of the first child, and it came to be a surprise that the gene isolated was CYB5R3, which leads to methemoglobinemia due to the deficiency of methemoglobin reductase, and it is a pathogenic homozygous variant. So for the further corroboration, we asked parents. Parents said that they might have noticed some cyanosis during a period of URTI. And at that time, we checked for the methemoglobin level, which was also significantly high, 11.5%. And we did cytochrome B5 reductase levels, which was 17.97, which are reduced. So hence, the child was started on antidystonic medications, ascorbic acid, riboflavin. There was some reduction in the dystonia, and the child has slowly achieved neck holding. So the presentation is probably congenital methemoglobinemia type 2. So coming to the literature review, initially we thought there are not much associations, but then we saw and realized that there are so many cases presenting with methemoglobin and neurological manifestations. This is the paper which we could find where they have collected all the 50 cases of methemoglobinemia with neurological cases and presented. So coming to the literature, some basic things. It occurs due to the mutation of CYB5R3 gene, and ultimately it leads to the reduction in the cytochrome B5 reductase enzyme. This enzyme is required for the reduction of cytochrome B5 to the transfer of electrons from NADH. And this in turn will catalyze the reduction of methemoglobin to hemoglobin. If this enzyme is deficient, then methemoglobin levels will accumulate. So it is of 2 types. Type 1 is present only in the erythrocytes, and hence there were only isolated cyanosis with no neurological manifestations. Whereas type 2, the enzyme deficiency present in all the tissues, hence the child can have cyanosis with neurological manifestations. Why are they causing neurological manifestations? Are because this cytochrome B5 reductase plays an important role in the fatty acid processing and also cholesterol synthesis, thus causing impaired myelination and delayed myelination. So coming to the clinical features, most of the children at birth will be normal. There may be some cyanosis during upper respiratory tract infections or some exposure to the agents. Around by 4 to 6 months, child eventually develop global developmental delay with failure to thrive. By 1 year, they eventually develop microcephaly with hypotonia, and by 2 years, severe dystonic posturing and choreoarthroid. Although both our cases had very early onset dystonia, so probably this is an expanding spectrum. This was the case review of the 50 cases in which cyanosis and isolated delay was present in 5 cases at the presentation, and motor delay was noted in 49 cases, and the predominant movement was dystonia. And the predominant MRI finding was also brain atrophy. So coming to the radiological features, there can be
Can you be quick, please? Because
yes. Delayed myelination, cerebral atrophy, and cerebellar atrophy. So probably this hypoplastic basal ganglia is a new thing, but there was one case report which also showed the similar findings. So treatment, we give ascorbic acid, riboflavin, and also we avoid precipitating factors. But during the crisis, we have to give methylene blue. Coming to the prognosis, the life expectancy is significantly reduced in type 2 children because of the swallowing difficulties and respiratory complications. And these are some precipitating agents which we have to make sure that the child should not receive, which might trigger methemoglobinemia. So take home message, it is difficult to notice cyanosis in a dark skinned people, but any child presenting with global delay, dystonia, failure to thrive, and brain atrophy, it is imperative to check for saturation and cyanosis. Heterozygote carriers also particularly susceptible to elevated methemoglobin levels. Therefore, it's crucial to avoid medications known to induce methemoglobin formation. Thank you.
Thank you. Dr. Shilpa ma'am, can you please give your comments?
Yeah, so this was a little different. It was mainly basically a pediatric case, methemoglobinemia with a neurological manifestation. Usually in our scenario, it is very difficult with dark-skinned people to notice cyanosis. And presenting with normal birth history and so early onset of dystonia and microcephaly, we had never thought of methemoglobinemia in these 2 cases. Both the cases were clustered together, one patient presented with 65% of methemoglobin, and the second patient presented with little bit cyanosis, but had predominant MRI features. And basically, it's a, I mean, we can help these patients. It can be treated early. It can change the prognosis a little bit, not a lot, because it causes a lot of tissue is involved in this cytochrome 5b reductase deficiency. So, lot of hypomyelination occurs, but it's a treatable thing. So, it's important to notice all the other reports at the same time. When we are seeing only MRIs and other things, all other reports also help. Similarly, like when you have early onset dystonia, doing a uric acid early may be helpful, because Leishmanians many a times do not have anything other than dystonia or hypotonia in the first year. Similarly, methemoglobinemia has to be kept in mind. That's why we thought that we'll present this case.
Requesting for expert comments from Dr. Biju.
Fantastic case. I don't know. I suppose if your clinically if your pulse oximetry is not concordant with your clinical findings, I suppose you need to think about methemoglobinemia, particularly in the light of. I think this is the only type 2 is the only situation where you get neurology, isn't it? Otherwise, you get all sorts of other features, isn't it? So,
yeah.
Fantastic case. Yeah. I saw that the other case was published by Mini and Kunyusar. So interesting. I've never come across it before. But the next time when you see somebody in this situation, I'm sure you'll think about it. I mean, what are the drugs which would normally cause methemoglobinemia? I mean, nothing which we normally use, isn't it?
So usually anti-seizure medications, some chloroquine like anti-malarial medications also can cause methemoglobinemia.
Valparin and phenytoin.
Yeah,
Oh,
and
phenytoin
basically,
okay.
if you use of asafoetida, some people use asafoetida for a local application in Indian scenarios, and that asafoetida also can precipitate methemoglobinemia.
I suppose the other thing would be if there's a history of methemoglobinemia in the family. I suppose that would be another alarm bell, I suppose. Yeah, interesting.
Yeah, so parental segregation is not yet done, and methemoglobin levels are like these are like last month's patients, so still getting worked up.
But also the treatment will only improve the cyanosis, isn't it? Treating the methemoglobinemia has not been shown to improve the outcome. Is that right, or does it improve the outcome? No.
Yes, it
No,
will not
it
improve
is
the
not.
outcome.
Yeah, it does not improve the outcome to a major extent.
Just the methemoglobin level will come down. That
Yeah, but
case
that
was
is
from
not
last
correlated with
September.
improved outcome, though. Yeah, it's interesting.
No.
Dr. Taj?
Good case. No much comments because I've not seen one. It's a good eye opener. But as far as the drugs that can actually cause methemoglobinemia, one of my experiences was cyclophosphamide. One of my cases with autoimmune encephalitis and cyclophosphamide induced methemoglobinemia. I never knew it was one of those drugs that can cause that. And of course, after things happen and then, go back on literature and then you realize, wow, this drug can cause that. And it doesn't come in one of the lists that I explained to the patient that, this can cause that. So, and it lasted for some time, even after taking off the drug, it took about 6 to 8 months before the patient came out of that. But it's a very good case. So I'll start looking for this one, if the patient comes with opisthotonus and cyanosis probably. Thank you.
Nice case. Dr. Sanam?
Thank you very much. This was really a very interesting case. I haven't heard about this condition before, so we should keep in mind this condition. Thank you.
If there are no more expert comments, can we go to the next presenter, Dr. Amaresh Roy from IGICH Bengaluru? and the moderator is Dr. Vaikunta Raju. Please share your screen. You can start presenting, please.
Hello.
You are not audible.
Dr. Amresh, we request you to please unmute yourself. Hello.
Please unmute yourself.
Hello.
Yeah, and put it on slideshow mode, sir.
Hello, it is audible, ma'am.
Hello. Yes, you are audible. Put it on slideshow mode, sir. Your PowerPoint
Okay.
isn't still activate mode. You can put it on slideshow.
Hello.
Yes, you can present.
Yes, ma'am. Ma'am, I'm Dr. Amadeus, from Indira Gandhi Institute of Child Health. My moderator, Dr. Vaikunta Raju, sir. I'm going to present a case of acute ataxia, the rare presentation of a relatively common disease. It's a 7-year-old girl from Bangalore. The informant is mother. Chief complaints were during time presentation were acute onset ataxia, which started 20 days ago, along with weakness on the left side 20 days ago. Starting with the presenting illness, there is sudden onset of left-sided weakness in the form of dragging of her left feet while walking, the mother noticed. And then the weakness of the limbs slowly progressed over one day to involve the upper limb, noticed when she faced difficulty in using the phone or handling the object on the left hand. At the height of the weakness, she was able to walk with dragging of left feet, was able to sit up, and was able to use her left hand with the shoulder, but could not maintain for a long time. There was facial deviation to the left eyelid with accumulation of food and drooling of saliva towards the left side on day of onset of this illness. On second day, the child started to sway on the either side, which was more on the left compared to right while walking, along with a broad-based unsteady gait with repeated falls. The child was unable to maintain the posture when made to sit due to unsteadiness. Her left-sided weakness improved partially over a period of 3 to 4 days after reaching the peak, except the swaying which progressed. The swaying had no diurnal variation or alteration with sleep or association with gait. Negative history: the child never had any episodes of seizure, never had any episodes of dyskinesia before. The child never had any weakness of the limbs or bulbar weakness in any period of time. There was no history of any jaundice. The child never had any episodes of headache, motion sickness, abdominal pain, or recurrent vomiting, photo or phonophobia. Developmental milestone: there is initial motor delay was there with good catch-up. Bus history: there was a history of recurrent loose stool, but was never admitted in hospital. History of poor weight gain was there since toddler age group, and there is also anorexia. This child was born out of third-degree consanguineous marriage. Birth history: during the period, the mother has antepartum hemorrhage during the third trimester. The baby was born by LSCS with a low birth weight of 1.9 kg preterm, and the child was admitted at NICU on day of life 1 in view of neonatal encephalopathy, and the child was discharged after 7 days with complete recovery. The baby was exclusively breastfed till 6 months, followed by initiation of complementary feeding with mixed veg and non-veg food. Socioeconomic status: the child belongs to Bij Prasad, class 3. Starting with the summary, the 7-year, 5-month-old girl, second born to third-degree consanguineous married couple, the born preterm with low birth weight. There was initial baseline motor delay predominantly with good catch-up, with a poor weight gain since toddler age group with history of recurrent loose stool. There was acute onset ataxia, left-sided human weakness of both upper and lower limbs with abnormal facial movements, deviation of the angle of mouth to the left, with the recovery over 3 to 4 days. On examination, anthropometry was showing height less than 3rd percentile for age and sex. Weight was more than 3rd percentile for the age, and head circumference was less than -3 standard Z score. Microcephaly was there. So on examination of the vitals were normal. On examination of head to toe, there was presence of strabismus, dynamic contracture of the ankle, hyperpigmentation of the knuckles, and hypertrichosis, and nevi was present on the right cheek. Examination of higher mental status, MMSE score was 25/30. Attention was fair. The child was alert, conscious, and oriented. And there's mild dysarthria with mild hoarseness of the voice was also there. Examination of the cranial nerves showed there is presence of exophoria on the right eye, and the other cranial nerves are within normal limit. On examination of the motor system, the muscle bulk was showing symmetrical wasting in all 4 limbs, proximal equal to distal. Tone was variable in all 4 limbs. Power was more than 3/5 on the right side. On the left side, although it was more than 3/5, there is positive movements on the left side. DTR was showing normal in all 4 limbs, and bilateral plantars were extensor bilaterally. Involuntary movements, there is a presence of chorea in all the 4 limbs, which was more predominantly on the left compared to right, with athetosis, which was more prominent on the right compared to left. The child walks with a short-stepped, wide-waist gait with the dystonia, and right more than left, and no change with of this gait with eye open or closer. So this is the video of the child. I'm not able to play that. Oh, sorry. So the sensor system examination was showing intact, normal posterior column sensation as well as normal foot touch and parent sensation. Cortical sensation was intact, and rhombus sign was not elicited. Cerebral signs, dysmetric and tandem gait could not be elicited because of the involuntary movements. There was presence of action tremor, and no nystagmus was there. Meningeal signs were absent. So we kept the possible differential like leak syndrome due to SARF1 gene mutation, MOG as associated autoimmune encephalitis, then CNS vasculitis, Mednick syndrome, organic aciduria, and vanishing white matter disease. So in points favor of leak syndrome were failure to thrive, anorexia, neonatal encephalopathy, global developmental delay with presence of human weakness on the acute onset on the left side, and point against were no bulbar weakness, no sensory hearing loss, or no visual impairment. Points in favor of MOGAD was acute onset multifocal clinical CNS insult, and point against were no encephalopathy with presence of progressive ataxia and GDD since birth with failure to thrive. Point in favor of CNS vasculitis were acute onset multifocal clinical CNS deficit. Point against were GDD since birth, no new onset cognitive decline, no past history of seizure or headache. And Mednick syndrome, point in favor were recurrent loose stool with clawing of the hands with global developmental delay. The point against were no deafness, no keratoderma, acute onset UMN type of weakness. Organic aciduria and points in favor were failure to thrive with GDD with variable tone all 4 limbs with acute onset ataxia, and point against was no history of encephalopathy. And points in favor of CSH or vanishing white matter disease was A sudden onset progressive ataxia with brisk reflex and point against where asymmetric weakness and pattern of recovery. This child was the rapid recovery was there within 3 to 4 days. So this is the MRI image of the child showing T2 flare axial images showing bilateral symmetric GP putamen and thalamic signal changes to hyperintensity. The T1 MRI image is showing symmetrical hypotensity in the bilateral GP and thalamus. This is a DWI axial images showing bilateral discrete symmetrical restricted diffusion in globus pallidus and tegment of the midbrain, and the ATC is showing hypotenuse area in the areas of DWI signal intensity changes. So this is the DWI coronal images showing bilateral symmetrical GP and brainstem signal changes. We did MR spectroscopy, which was showing low NNA peak with no significant elevation of the choline peak. There's no specific lactate elevation. Further workup we did, which was showing ammonia was 56 micromole per liter, lactate was borderline high, 23 milligram per DL with normal ABG. SGOT was mild high with 80 and normal SGPT. CSF OCB was done suspecting MOG associated and encephalitis, which was negative, and MOG antibody was also negative. Tandem mass spectrometry was sent suspecting organic aciduria, which was also normal for the child. So we suspect Wilson disease in this child based on the clinical phenotype. So we did serum ceruloplasmin, which was showing 3.6 milligram per day, which is very low, and 24-hour urine copper was showing 250 microgram per day. USG whole abdomen was done, it was normal, and 2D was also normal. Ophthalmological evaluation was done at that time, which was showing presence of KF ring in both the eyes. So we sent whole exome sequencing, which was showing homozygous mutation of the ATP7B gene, which was pathogenic. So final diagnosis was mild global developmental delay, motor more than cognitive, ataxia with dyskinesia, predominantly chorioathetosis, with stroke-like episode, with quadriparesis left more than right, with microcephaly, with squint, with visual impairment, with failure to thrive, secondary to neuro-Wilson. So conclusion of first case is the neuro-Wilson can present with acute ataxia with stroke-like episode, can mimic like mitochondrial disorders, can improve partially with symptomatic treatment without any chelating agents also, like in our case. And the DWI signal changes in the MRI brain can present during the early stage of the disease. Thank you.
Dr. Vaikunta Raju, sir, your points, please.
A few reasons. One is the presentation is usually will consider Wilson is in chronic disorder with progressive disorders. Now that is the baseline. Some delay was there, and failure to thrive also was there clinically. These are some of the unusual features, and child has some improvement was there, almost partial improvement, like 70 to 80%, significant improvement with just symptomatic treatment without chelating agent. And MRI is showing very unusual pattern of involvement, like changes in the diffusion weighted also. These are some of the unusual features. So in this condition also, you should consider Wilson disease one of the possibility as it is a treatable condition. Thank you.
Dr. Biju, please.
Fantastic case, and to be honest, like I'm yet to find a positive Wilson's, because as routine, we always with every child we do neurometabolic tests, we look for Wilson's, but I'm yet to find a positive Wilson's, and Wilson's never occurred to me like when the case was being presented, but it just shows how important it is to include Wilson's in your differential whenever you are faced with a movement disorder or any progressive condition, any suspected neurometabolic condition. Absolutely. Again, highlighting how important clinical approach is, and again shows how fascinating the world of movement disorders are.
Dr. Taj.
Hi. So thank you for a very good case again. So my thoughts were running through probably Lee disease, one of the mitochondrial cytopathies, one of those familiar hemiplegic migraines, the Cagna1A variations. So the thing that threw me off was the GDD. I mean, I probably would not have suspected Wilson's, neuro-Wilson's in a child who has been presenting with the global developmental delay. So if your biochemical and genetic, what do you call, parameters, genetic testing and biochemical parameters does fit Wilson disease with such a robust MRI and with global developmental delay. So that could be a possibility of, double pathology. It's neuro-Wilson's, we don't suspect neuro-Wilson's if you're talking about a child who's presenting with a global developmental delay, something that's already happening, in the early stage of myelination and proliferation and neuronal migration. So these are my thoughts, yeah. But it's a good case.
So that possibly my comment that this child is a premature baby and a low birth weight, that may be the reason for initial developmental delay. Afterwards, there is a good catch-up was there. So that developmental delay not be related to Wilson's disease.
Thank you.
Ma'am, Dr. Aparna has joined.
Dr. Aparna can then share her screen.
Sure.
Now we have Dr. Aparna from Rajagiri Hospital, Kochi, and our moderator is Dr. Darshan Das.
Is it audible? Yes, ma'am, you're audible. Okay. Put it on side for a moment. Good evening, all. I'm Dr. Aparna from Rajagiri Hospital, DNB resident in Department of Pediatrics. I'm presenting a case of 9-year-old male child referred to us with complaints of recurrent falls that began approximately after 3 years of age, with gradual increase in frequency for the past 2 years. There is no history of loss of consciousness, stiffening, seizures, abnormal eye movements during these episodes. He had a history of congenital hypothyroidism and on thyroxine 50 micrograms. He is a single child of non-consanguineous parents. There is no history of previous abortion. Mother had antenatal hypothyroidism. All the antenatal scans were normal. It was a term normal vaginal delivery. He cried soon after birth, and there is no perinatal complications. Moving on to the development of the child. Gross motor, he attained head control at 5 months, stand with support at 2 years, independent walking after 3 years. There is a history of recurrent falls. Speech vision was normal. Toilet trained after 5 years. Rarely some bladder incontinence once in 1 to 2 months. He opens bowel regularly. No concerns around hearing and vision. Parents report some cognitive difficulties, but formal assessment is not done. Moving on to the examination. Child is awake, alert. There is a dysmorphism, flat feet, wide sample gap between first and second toe on bilateral feet, microcephaly. Eye movements were normal, no cranial nerve abnormalities detected. Chorioathetoid movements mainly involving lower lip, proximal more than distal, and trunk, rarely shoulders. Significant joint hypermobility and hyperextension of knees. Power, normal in all flexor and extensor group of muscles. Deep tendon reflexes are symmetrical.
I don't know. Someone has understood. No, it's your case, that's why you understood. But
एक minute, Asmita, can you mute everybody else, Asmita?
Yes.
Asmita, yeah, and continue, beta. Please continue here. We have overshot time. Please
Hello,
continue.
ma'am. Hello, ma'am.
Please continue. We have overshot the time. Continue, huh? Please continue. Yeah.
Aparna, can you show the first video?
Okay. Yes. This is the video of the child initially when presented to us. He had recurrent falls while walking, mainly noted after 3 years, and there is a gradual increase in frequency for the past 2 years, and associated with choreo movements. Previous investigations were normal. MRI brain and spine were normal, and conduction study and CPK were normal. We did a genetic analysis in which whole exome sequencing showed heterozygous autosomal dominant mutation NKX2, and mitochondrial evaluation was negative, and child was diagnosed as a case of benign hereditary chorea. We started on trihexyphenidyl 2 mg thrice daily, and there is good reduction in fore and chorioacetal movements. This is the video showing after treatment. There is a good reduction in the chorioacetal movements and falls. Child is able to balance while walking. Differentials include seizures, paroxysmal kinesiogenic dyskinesia, some genetic dystonia, Sydenham's chorea, and Wilson's disease. Moving on to the conclusion, in children presenting with recurrent falls, an underlying movement disorder can be a rare possibility. Careful history taking, an examination, and review of videos when available will help immensely in understanding the nature of falls. If there is associated congenital hypothyroidism and respiratory problem, possibility of brain-length thyroid syndrome should be considered. Dystonia can be a presentation in child with benign hereditary chorea, which is potentially treatable. NKX2-1 testing should be considered in those with history of neonatal hypotonia, motor developmental delay, and early onset of hyperkinetic movement disorder with predominant chorea or dystonia. Some brief description about benign hereditary chorea. Benign hereditary chorea is a rare childhood onset movement disorder characterized predominantly by non-progressive chorea. It has autosomal dominant pattern of inheritance in which deletion involving NKX2 gene. Clinical features are mainly motor features. Classical motor symptoms in benign hereditary chorea include mild to moderate hypotonia with delayed motor milestones in infancy. Onset of chorea is in early childhood. Ataxia and upper limb intentional tremors. Limb dystonia, motor and vocal tics may also involve. Recurrent rope attacks or frequent falls have been reported, and speech disturbance may be also associated. There may be a reduced level of cognition have been also be reported, and associated psychiatric symptoms may be present. Neonatal respiratory failure and high serum thyrotropin concentration, motor delay, hypotonia, and truncal ataxia may be the presenting complaints. Thyroid dysfunction usually takes in the form of congenital hypothyroidism. And this is the spectrum of clinical spectrum of benign hereditary chorea, mainly involving brain, lung, and thyroid.
Request you to wind up, please, because we are overshooting time.
Okay. Okay. That's all. Treatment is mainly trihexyphenidyl, corticosteroids, sodium valproate, propranolol, except levodopa, and tetrabenazine. We tried in this child, we tried trihexyphenidyl. That's all. Thank you.
Thank you. One quick comment from the moderator, Dr. Das, please.
Sorry. This case is interesting because the child predominantly had a lot of uh, dystonic episodes while sitting, as well. She was sitting in the class. He would actually kick the front bench. And the videos were very interesting. We thought this was predominant phenotype was dystonia rather than chorea, but he did have a lot of subtle choriform moments. The hypothyroidism, which was something that we made us think about it. I would actually like to ask others' experience in treating benign hereditary chorea. We had a child who unintentionally received steroids for ITP while we were doing a fellowship, and suddenly had an improvement. And that's where I had the first experience of steroids working well in children with benign hereditary chorea. When we look at the literature, there are some reports, but I just wanted to know everybody's thoughts on what is the collective experience on using different medications for this condition.
You, Dr. Taj. Thanks for presenting.
Thank you for the good case, Dr. Lakshan. So my comments on the video, I mean, most of the times, those people who do lots of movement disorders, we tend to agree to disagree in many of the phenomenologies, and that's very common. So as far as this case is concerned, I find probably the major predominant phenomenology would be choreoform movements, a lot of flaying component there, probably some ballistic movements were also noted. Apart from that, the other obvious aspect for this child was the child was very hypotonic, and you can see there's some component of hyperlaxity of the joint, especially the knee joint. Is very much hyperextended, and he seems to be slightly unstable based on that. So NKS2 mutation and probably some other components of it could explain to that. So I would still think it's the predominant chorea rather than dystonia. And yes, majority of most of the cases tend to have lots of falls, and they've got difficulty in walking. They tend to fall with some subluxation of the knee or the ankle joints. Now, as for treatment, yes, I've tried treating a few of them. None of them were very successful. And yes, it's very interesting because I did lean back on some of the case reports some time ago, probably a decade ago, where steroids improved. Yes, they do improve, but those improvements are transient and probably not justifiable to give such a toxic drug for a child with, kind of a benign movement disorder for a transient improvement. So that's my experience based on that. Those anti-choreoform agents that I've tried, benzos and sometimes atane, they don't really work that well. I had a child where I thought initially tetrabenazine was working, but after some time when the mom took it off, the child remained so. So I think it's a natural history of NKX2 where they tend to kind of slowly improve with time. So not really our medication is doing the work. Thank you.
Levodopa, have you tried, Dr. Taj?
Yes, I've tried, but not successful.
I have not tried levodopa in this case. Generally, my experience has been with not so well tolerated in patients. So
I know some people who use levodopa. Yeah,
but the majority of them tend to spontaneously improve or stay static for a very long time. And I think the mechanism of the brain is such that the brain gets acclimatized to the choreoform movement and the incoordination to a certain extent, and then they tend to compensate better. So may not need much medication, may not need treatment unless the child is falling very frequently and so forth.
We just conducted a poll among a few neurologists, just sharing the videos, and it was interesting. A lot of them voted for dystonia, some of them voted for chorea. So it was just yeah.
Would you agree? In pure chorea, we've seen lots of children with really bad chorea. They don't fall that often because their balance is still maintained. and they will all do all sorts of dancing, but still would manage to stay on their feet. In Korea, even if it is really bad Korea. But obviously, with the ataxia and the hypotonia and the ligamental laxity, etc., I mean, this is quite characteristic, in this condition, like there is increased falls. But pure Korea, I mean, they don't often fall that lot.
Even majority of our Sydenhams with very severe choreoballistic movements, they don't fall.
Yeah.
They will be walking around with, flaying hands and feet, but they'll be still walking around. But I think the component that kind of promotes lack of balance or incoordination of fall, probably the hyperlaxity, the hypotonia, lack of power, and ataxia, part of the ataxia.
Condition where you think about hypothyroidism and movement disorder is the syndrome, Allen Herndon Dudley syndrome.
Dundee-Hodley, yeah.
Yeah.
Thank you. Dr. Sanam, you want to add something before all of you experts are going to give take-home messages? We have overshot time. We are 20 minutes overshot time, and we have 123 participants. So we are going to have your comments and then one final comment from all three of you.
No, I don't have any additional comments for this case. And thank you for all the speakers, for all the cases. It was a very amazing night for me. Thank you for your invitation, Shefali.
Thank you, Dr. Sanam. But you give a message, take home message to the attendees.
Okay. The most important thing for today's meeting is, I think, our clinical view is the most important thing when we are investigate a child with movement disorders. So we should be aware about the clinical phenomenology, and we should be sure about what we are looking for the child. So we should investigate the radiological images, the genetic analysis, and all the other things based on our clinical diagnosis. Thank you.
Thank you. Professor Hassan, you want to wind up Turkey before we come back to London and UAE and then Malaysia? Dr. Hassan?
Yeah. Hi, Dr. Shefali and Dr. Biju, all the friends. It was a fantastic meeting. Thank you very much for your inviting for us. We are very happy to be involved in this meeting, and also I would like to say good night, and then see you next webinar.
Thank you. And
Thank
we
you
have
very
a
much.
Ma'am, you are
Sorry.
muted.
So yeah. Sorry. I got.
Yeah,
I'm saying thank you. We are just having next week off because of the annual conference, 8 to 10. We come back on 14th and looking forward for more participation across the globe. Dr. Biju, take home message.
I think the key message was given by Dr. Sanam in her talk, and I would just reiterate that movement disorders are fascinating, and clinical phenomenology is always, what you need, and that's number one in terms of making a diagnosis and formulating a management for the child. And congratulations, Dr. Shefali and Mahesh and team for these series of webinars. They've been fantastic, and today each and every case has had a lesson, and you can't ask for more. Fantastic.
No, I think it's all participation all over, and we're looking forward for case presentations from outside India as well. And you have wonderful experts. Dr. Taj, I'm really grateful. You have 5 consecutive Wednesday nights. You have stayed up till midnight. I hope
quite
your
late.
family has not disowned you actually. 5 consecutive nights.
Close
I'm
to.
really grateful to you. Okay.
So my take-home message, thank you, Professor
Thank you,
Shefali and the entire team, for a very wonderful, fantastic, and stimulating month. Movement disorders are unique, and those who enjoy it, we always enjoy it. And I thank all the experts, and Dr. Biju, Dr. Hassan, Professor Hassan, and all, and Dr. Sanam for sharing your expertise. And for the attendees, of course, our message is the same: lean back on phenomenology, focus on phenomenology, you get the phenomenology right, and then fall back on other clinical features, and probably finally go to genetic testing and don't do a reverse phenotyping. Yeah. Thank you.
Thank you. And I think radiology also aids sometimes, and always better to sit and discuss. Anybody else from the SIG wants to make any comments? And if not, Mahesh, are you there? You had gone
Yes,
off in
ma'am.
between. Yeah, okay, then
Yes,
we
ma'am.
can just sign off. Yeah, thank you. And thank you
Yes,
very
sir.
much. And looking forward to people coming to Vellore next week. Yeah, Mahesh. Sign off,
I thank
Mahesh.
all the presenters and their mentors for a wonderful case presentation. I'd like to thank Dr. Sanem for a wonderful clinical case-based approach to movement disorders. I'm sure you all enjoy the cases today, and we'll meet next month with the neuroimmunology SIG. It will be starting from the second week of February. Thank you.
Thank you. Thanks.
Good night. Good night.
Good night.
Thank
Good
you.
night. Bye. Thank you.
Bye. Bye.
Bye.
Bye, Hassan.
Bye.
Good night.